Hello. Thank you for coming along to this session today. So my name is Shoaib. I'm one of the immunology consultants at Salvador Hospital. I would like to welcome you all to the 5th edition of the ESID Juniors most successful workshop with great feedback throughout the last few years. Pitfalls in PID, expect and expected. In the last few years, we have had very interesting cases, great presentations, and outstanding moderators and terrific expert panel. In addition, exciting discussions and learning across borders and countries. However, this year has been a real challenge to actually select only 4 cases out of all the outstanding cases we had. The highest score were given to those cases where the final diagnosis was unexpected, considering the initial clinical manifestation and laboratory results. Now, without further ado, I would like to welcome our expert panel this morning, Fabian Hope, Sylvia Sanchez, Ramon, and Fabio Canducci. Although none of the expert panel require introduction, however, because every year we have new juniors doctor, and in this meeting we have over 180 ESID juniors. I shall start with a 1-minute each introduction to perhaps tell us about your main area of interest. If I start with Fabian, you've got like 30 seconds to 1 minute to introduce yourself.
Okay, hello everyone. I'm Fabian Haug. I'm a pediatrician. I'm placed in Munich, where I'm heading the Department of Immunodeficiency. And so clinically, I take care for all the different kinds of PIDs that come along. And my research main interest is in identifying novel signaling disorders in monocytes and lymphocytes. Yeah, thank you.
Thank you, Fabian. And Fabio, over to you.
Hello, I'm Fabio Candotti. I'm also a pediatrician. I'm currently working in Lausanne at University Hospital. I trained in Italy first and then in the US for 20 years. And working there on developing gene therapy strategies for primary deficiency diseases and looking for genetic causes of new disorders.
Thank you. Sylvia, over to you.
Good morning. I'm Silvia Sanchez Ramon. I'm a clinical immunologist based in a university hospital in Madrid. I'm focused on adult primary immune deficiency and also in secondary immune deficiency.
Thank you very much. So let's welcome our first case presenter. So over to you, the platform is yours now.
Hello, good morning. My name is Delphine Bogaert, and I will start with the first case in this session. I have nothing to disclose. I will tell you about 2 brothers who were first referred to our hospital over 10 years ago. The oldest brother was at that time 9 years old, and we learned that in the first years of life, he had recurrent respiratory tract infections, but he rarely needed antibiotics, mainly treated with inhalation therapy. However, at the age of 7, he first started to show lymphadenopathies and splenomegaly, and had his first episodes of neutropenia and autoimmune thrombocytopenia. Those were treated with IVIG, but as you can see here, he evolved to chronic cytopenias requiring maintenance therapy with Fansidar after he saw improvement of the cytopenias. At the age of 9, he showed an episode of autoimmune hemolytic anemia, which resolved after a short course of steroids. When he came to our hospital, further workup was done, obviously. Biopsies were taken of the lymph nodes and bone marrow and were reported as normal. Viral PCRs were negative. Gross workup of his immunological lab was also normal, so he had normal TB and NK cell subsets, immunoglobulins, and normal antibody responses to vaccination. However, we did find that his double negative T cells were repeatedly increased, between 4 to 6% of his total lymphocytes. When we look at his younger brother, he shows a similar phenotype. He also had recurrent respiratory tract infections in the first years of life. And around the age of 6, 7, he started to develop chronic generalized lymphadenopathies and chronic autoimmune thrombocytopenia, which also required maintenance therapy with Fansidar. When we looked at his lab workup, we also see that the main lymphocyte subsets were within normal ranges. However, in contrast to his brother, he did show signs of antibody deficiency. He had a low IgA and IgG2 subclass, and he had poor antibody responses to polysaccharide vaccination. Similar to his brother, he had an increase of his double negative T cells, also between 4 and 5% approximately of his lymphocytes. Otherwise, the brothers did not show any other problems. They had a normal development and a normal growth pattern. The family history was negative. Parents were healthy, non-consanguineous, and there was no PID or autoimmunity or other diseases known in the family. Now, I know you still have limited information, but just to explore what you are thinking, I already have 2 quick questions. So, first question is, what would be your first diagnosis based on what you already know now? Do you think it's ALPS?
Thank you. So we're going to have a voting now. So that will be the first question for voting. If you all can access the poll section, and basically going to have these four options. So what's your first diagnosis? Autoimmune lymphoproliferative syndrome, an immune dysregulation disorder, difficult to tell which type, an antibody deficient disorder, or combined immune deficiency. We've got 1 minute to vote, and then we can close the, 3 seconds. Okay, can we close the vote now? Wow. Brilliant. So over to the expert panel at the moment. So we've got this presentation. Maybe Fabian, do you want to comment on this result so far?
Yes. I was somehow expecting this answer, but I would not go for autoimmune lymphoproliferative syndrome, because in these young children, I would expect a more hypergammaglobulinemia phenotype with IgG, IgA being increased. And I think the pitfall has been the poor classification of the double negative T cells, because we do not know right now from the presenter which kind of double negative T cells we are facing. Is it really a TCR alpha beta double negative T cells, which might be related to ALPS, or is it gamma delta, or is it exhausted T cells? This is not yet clear. So I think we need more information on the immune phenotype, and I would go for D, but let's see.
Okay. Let's go in with the presentation and find out what we're going to find. So over to you.
Just to say, it's alpha beta double negative T cells. So the second question. And now that you have a working diagnosis in mind, what do you think is the most likely inheritance pattern that could fit your diagnosis to help guide your genetic testing?
Thank you, Dolphin. Let's go for a vote again. So you've seen the option here. You've got 30 seconds to vote. Interesting to see, kind of going up and down the columns. Right, so let's close the vote here. So maybe Fabio, do you want to comment on this?
Sure. If this were not a section on expected and unexpected, one would say X-linked recessive, of course. But I agree with Fabian on answer number D for the previous question. So based on that hunch, I would say I probably would favor an autosomal recessive inheritance in this case.
Okay, let's find out. Dolphin, over to you.
Yes, some interesting answers here. So at first, we also thought of ALPS, but it was quite difficult to match a likely inheritance pattern to that because there are no X-linked recessive mutations described with ALPS. But anyway, we went along with our diagnostics, but that all turned out to be negative. So the biomarkers were negative, the FAS-mediated apoptosis assay was negative, and more importantly, the genetics for the FAS and FAS-ligand genes were also negative. Now, in the years that followed, some interesting changes appeared in the brothers. So the oldest brother did not have antibody deficiency when we first saw him, but over the years, his immunoglobulins progressively declined, and he evolved to profound IgG and IgA deficiency, and also showed loss of his polysaccharide antibodies against pneumococcal infection. We revaccinated him, but again, after revaccination, his antibody responses were absent. When we looked closer at the B cells, we saw that there were no memory B cells and mostly naive B cells. And because of this and the fact that he had recurrent respiratory tract infections, we started him on substitution therapy. More recently, at the age of 18, he started to develop symptoms of arthritis. We did not detect any autoantibodies, but he was started on methotrexate, after which his arthritis improved somewhat. The youngest brother kept having episodes of autoimmune thrombocytopenia. So the Fansidar treatment was switched to sirolimus or rapamycin, after which the episodes were controlled better. And in the beginning, he had an IgG2 subclass deficiency, and he also evolved to profound IgG deficiency. And similar to his brother, he had no memory B cells and mostly naive B cells, and was started also on IgG substitution therapy. So now we are a few years later, we have some more information. What is your diagnosis at this stage?
Let's go for a voting again. So we've got 3 options here, and we have got 20 seconds to vote. Over. Great. I can see some changing their minds. So shall we stop the vote? And over to you, Sylvia. What do you think about this?
I'm sorry. It was okay. I agree with the most of the audience in common variable immune deficiency.
Yes.
Right. Brilliant. Well, I've got a question here before we proceed. Why did you do genetics for FAS with negative biomarker? Do you have any answer for this, Delphine?
Yeah.
Yes, we mostly wanted to be sure, but indeed, even with somatic mutations, you would expect that the biomarkers would be increased, but we did it anyway to be sure. And I also believe that with FAS ligands, the biomarkers may not be always that abnormal, but I could be wrong on that. So yeah, we did it anyway.
Sure, let's find out more then.
So indeed, at this stage, we are a bit puzzled about the diagnosis. CVID was a strong candidate, but as you know, that's more of an umbrella diagnosis. We performed Sanger sequencing of CTLA4 and of the APDS genes, but that was negative. And because, it became a bit too much to Sanger sequencing, we went to whole exome sequencing. And that showed us a very interesting variant. It was a heterozygous variant in STAT3 in both brothers. And when we looked closer at the variants we found, we learned that it had already been described in literature in several patients, and that it was shown to be a pathogenic gain-of-function mutation in STAT3. So given that our patients had similar features, clinical features, than the patients described in literature, that confirmed our diagnosis. We did segregation analysis in the family, And we found that none of the parents had the germline mutation. So that was a bit curious. So would you like to go and explain how none of the parents has a mutation?
Thank you. So over to voting now. You've got 10 seconds this time.
So do you think our genetic testing is wrong and we need to repeat it? Is germinal mosaicism? Or maybe the father is not the real father? Or you don't really care why the parents don't have it? You have your diagnosis and your patients and you're happy with that?
Brilliant. Right. So, Fabio, do you want to comment on these results?
Of course. I mean, I don't really care. Depends on whether the family is planning to have additional children.
No.
And it depends. It's not you who decides whether I do care or not. It's the family who decides whether they care or not. So this is not you to answer if you want to dig in more in this. But if the family decides with you pushing them a little bit towards having more clarity, I would go for germinal mosaicism as well.
Brilliant. Thank you very much. Over to you, Dolphin.
We first checked if the father was indeed the father, and that was the case. So now we are doing further workup to investigate the germinal mosaicism, which is most likely explanation, but we don't have the final answer yet. And then the final question is now that
only 1 minute left.
now that we know the genetic diagnosis, would you change the treatment of the patients?
Got 10 seconds to vote. Here we go. Stop the voting. So, Fabio, do you want to comment on that?
We cannot hear you, Fabio.
Fabio, I think you are mute.
Yeah, sorry. Yeah, so I agree with the majority. Not doing anything for me is not an option. I've seen some devastating consequences of STAT5, STAT3, function over the years, and that's certainly a disease that needs treatment. Whether or not this is it justifies going for a transplant, that will have to depend on me on the effects of the JAK inhibitor.
Thank you very much. I think we have got only 30 seconds for you, Dolphin.
So what we did in the brother that had the arthritis features, we started a JAK inhibitor because that is reimbursed in Belgium for patients with arthritis, and he showed much improvement under that. In the other brother, we didn't change anything yet. So that was the end of my presentation, and I'd like to thank all the teams that worked on this case.
Thank you very much. I think we've run out of time this time, but next time I have to catch up with the time. Thank you ever so much. If you can share your screen, and then I can welcome the second presenter to share your screen. Thank you, Vanessa.
Hello, everybody. My name is Milenova. I'm a pediatrician from Sofia, Bulgaria, and I'm doing a second residency in clinical immunology in our expert PID center here in Alexandrovska Hospital. So, we will present a clinical case of a 5-year-old girl who was born from normal pregnancy with normal physical and psychomotor development with no dysmorphic features. She was regularly immunized up to 14 months of age. After her BCG vaccination, she developed local BCG infection, and from the age of 4 months, she presented with multiple respiratory and gastrointestinal infections, followed by hospital admissions and intravenous antibiotic treatment. At 16 months after her MMR live vaccination, she presented with high fever and diarrhea, followed by generalized rash and of multiple joints. Her CBC showed leukopenia with elevated markers of inflammation, ESR and CRP. So her condition rapidly deteriorated with generalized edema, ascites, and pericarditis. And she was transferred to ICU, where pulse therapy with corticosteroids and broad-spectrum antibiotics was performed. At 2 years, she developed autoimmune symptoms with non-erosive asymmetric arthritis, and treatment with medro and hydroxychloroquine was initiated. So, my question number 1 for you is, what is the most likely diagnosis?
Interesting. So let's start the voting now. So I'll try to keep the time. So I've got 10 seconds to vote. Is it a vasculitis? Is it macrophage syndrome, SLE, immune deficiency, or others? Right. So everyone kind of thinking about immune deficiency. Stop the voting, please. So Sylvia, what do you take of this answer? Do you think it's an immune deficiency so far?
Thank you. Yeah, I agree with B. I think it's an immune deficiency in this girl. I would go, if I can, for systemic inflammation with urticaria, so auto-inflammatory in the first place. Let's see.
Okay, let's see the challenge. Over to you, Vanetta.
Well, Kawasaki disease was the first choice because so the echo shows slightly enlarged left coronary artery with small pericardial effusion. It resorted on the next day, and she was started on aspirin therapy, but her condition and her symptoms get back worse. So she had a bone marrow biopsy for macrophages activating syndrome with no signs of malignancy or hematologic diseases, and with no verification of hemophagocytosis. And at this point, she had a workup for immune deficiency. As you can see, the investigation of the cell immunity showed significant lymphopenia with a decrease of almost all the studied patients, significantly reduced total T lymphocytes up to 19%, their major subpopulations, and B lymphocytes up to 9%. Compensatory increase in NK cell count, also significantly reduced naive helper induced T cells with the predominance of a memory phenotype. So this indicated T minus, B minus, NK plus phenotype. Also, she had missing, very reduced missing T cell function. The investigation of her humoral immunity showed elevated ANA titer, positive DNA antibodies, elevated antiphospholipid antibodies, elevated IgE, and missing post-vaccination immune response towards diphtheria toxin. And my second question for you is, what other specialized tests should be done?
It's getting more exciting now. So Vanessa, thank you for the question. So over to you guys to vote. We have got 10 seconds to 15 seconds. It's getting more and more and more interesting. So everybody going for genetic testing, obviously 2020. Yeah, what are you going to think about? Anyway, so let's stop the voting. And Fabian, do you want to comment on the results so far?
Yes, I don't see them. The results, okay. Yeah, of course, genetic testing is necessary in these patients. And in addition, I would go next for chimerism study because there could be a maternal engraftment, which would be helpful for the next steps. I don't see the benefit of immune phenotyping of patients' umbilical cord blood cells. This might be interesting, all right, but yeah, I would go for C, B, and when there's a lot of resources around, maybe A.
Right, let's find out what you have got for us, Veneta.
Okay, luckily, her umbilical cord blood cells were stored at our National Public Donor Bank, and immunophenotyping was performed to clarify the available immunodeficiency. It was found strongly decreased total T lymphocytes up to 2%, a lack of B lymphocytes 0%, elevated NK cells 97%, which confirmed combined immunodeficiency with T minus, B minus, NK plus phenotype. Because of the predominant memory T cell phenotype, a chimerism study was performed, and based on the established 5 informative WOCI maternal allele specifics not found in the child, 0% maternal chimera was established in patients' DNA samples isolated both from umbilical cord blood unit and peripheral blood. So of course, she underwent genetic testing, and a pathogenic variant in RAG1 gene in a homozygous state was established. Well, this mutation is found so far only in 2 patients and is considered to be the cause of atypical, leaky, severe combined immunodeficiency with partial function of RAG1 gene. Well, in such patients, dominate infections in infancy and infectious complications, followed by chronic autoimmune complications with age. The clinical course, as you can see, at 4 years, she developed alopecia totalis, and the treatment with hydroxychloroquine was discontinued. At 5 years, she suffered from severe pneumonia with CT results for pulmonary bronchiectasis, and antibiotic prophylaxis was, of course, initiated. Up to the present time, the child has frequent infections, mainly on the respiratory system, without the presence of any joint symptoms. And my question number 3 for you is, what is the management for atypical or leaky severe combined immune deficiency?
Thank you, Vanetta. Coming from Kawasaki to macrophage activation syndrome to RAG, that's just amazing, Skip. Right, so over to you guys. You have got 5 seconds to vote. So everybody going for transplant is straight. Wow, amazing. Right, so Fabio, it's your turn now. Do you have any comments so far?
Can I see the results? Okay.
Yeah.
All right. So the consensus therapy for RAG1 deficiency SCID, of course, is allogeneic bone marrow transplant. For a leaky SCID, you always have the question mark, of course. But in the long run, I think a resolutive treatment with a bone marrow transplant is certainly would be certainly my first choice. I just want to put a plug there for gene therapy. Because there are trials of gene therapy for RAG1 deficiency that are starting, and therefore, especially for potentially a leaky SCID in which the phenotype is less severe, perhaps a enrollment in an experimental form of therapy like gene therapy could be considered. But yes, my first choice would be to look for a donor and plan for a transplant.
Thank you, Fabio. Over to you, Vanetta. You've got 1 minute left.
Thank you for your comment. Our patient has a live and healthy sister, so we HLA typing, but unfortunately she is not a match, and so currently we're not discussing bone marrow because of the compliance of the patient's parents. And she's only on antibiotic prophylaxis without the need of immunoglobulin replacement therapy. So that's...
Thank you very much, Vanetta. That's really interesting case. I've got only one question, and then we can go ahead to the next case. So I've got a question here. In a subset of leaky SCID patient with RAG1 mutation, high levels of gamma delta T cell are observed. Did you study this population of T cell in your patient?
Could you repeat, please?
So they said the question is, in leaky SCID, usually they see a high level of gamma delta T cell. Have you seen that in your patient? Go
No.
back to your results. No, you don't see that. Interesting. Leaky skid, always expect the unexpected. Thank you very much, Vanetta. If you unshare your screen, we'll go to the third presenter, Lehman. Over to you.
I would just use the time and really make the point that this patient should be transplanted, even with an alternative donor, because the prognosis will be very poor. And when the parents are non-compliant, this is an additional reason for going to transplant in the interest of child, but because they will not be compliant with therapy as well. So you should really try to get this child transplanted.
Also, maybe gamma globulin could be recommended because of the bronchiectasis, which impact on the lung prognosis. So just to evaluate that.
Thank you ever so much. Thank you ever so much. I've got so many questions here, but I think we'll wait in the interest of time. We'll go to the next case, and then at the end of the 4 cases, if I've got more time, we can go through the questions we have. So, Liman, if you want to share your presentation. Thank you. Over to you.
Good morning, everybody. Can you see my screen? Yeah. So I'm Mutlu. I'm one of the specialty trainees in immunology in Birmingham, UK. I would have been one of your hosts had we not had COVID and we managed to bring you all to Birmingham, but obviously wasn't to be. I would like to present today a case of unusual infection in an adult patient and a 50-year-old man with combined immunodeficiency. I've got nothing to disclose. So this gentleman was referred to us by a respiratory physician in a nearby town. And at the time of referral, he was 50 years old. He's 54 now. He had previously been completely well, only child, bus driver, avid marathon runner, healthy man. And then at the age of 49, started having these recurrent pneumonias, which were quite protracted. He presented to the physicians late, but nevertheless, he had several of them, I think 3 or 4, by the time his immunoglobulins were checked. And we found out, and he was found to have no immunoglobulin, no IgG, A or M. He had some history in his 20s of alopecia totalis, vitiligo, and some transient anemia, but he was a long distance marathon runner, so he was a fairly fit man. But over the course of the 18 months of his recurrent pneumonias, he had become quite unwell. He wasn't able to keep his job down. On examination, he had some palpable lymph nodes. He had barely palpable small splenomegaly on examination, and then chest examination consistent with consolidation. He was also losing quite a lot of weight. Microbiology had yielded nothing from the respiratory physician. CT scan did show the consolidation on the lung parenchyma and also showed above and below diaphragm lymphadenopathy. So at this point, everybody's thinking this is a lymphoproliferative issue with absent G, A, and M. His initial lymphocyte analysis showed normal B cells, normal total T cell count, and NK cell count, nothing too suspicious. He had a bit of CD8 T lymphocytosis to begin with, but we monitored that, and later on we looked further into it, and we found a beta TCR small clonal population. We did a bone marrow biopsy, which wasn't convincing of a possible large granular lymphocytic leukemia, but that was the thought in everybody's mind. We were simply not sure what was happening. HIV was obviously negative, HTLV was negative. His CMV low-level positive PCR was slightly increasing, and the microbiology for his sputum was repeatedly negative. So he was having cough and sputum at this point. So take a minute. So this question probably is 2 questions in one, but we have a differential diagnosis in mind. So my first question is going to be, what is the immediate management in this clinical scenario of this clearly unwell man? A, immunoglobulin replacement with treatment for his CMV, so the titers are increasing and his CD8 count is also increasing. B, immunoglobulin replacement, but his CMV doesn't need treating. immunoglobulin replacement with CMV, with antibiotic prophylaxis and treat his CMV as well? Or does he have a leukemia? Should we treat that as well and also replace his immunoglobulin and treat his CMV? So I will.
Thank you, Liman. So that's really interesting. Already you can see the answers all over the place at the moment. A bit challenging. So we'll stop the voting. Maybe start with Fabian. Do you have any questions or comments so far?
I think it's straightforward to replace immunoglobulins. I would, in the first place, not treat CMV infection, but closely monitor to see how the situation evolves. And for the antibiotic prophylaxis, it depends on the chest CT scan and how the patient improves under immunoglobulins. Maybe it would be sufficient to have inhaled antibiotics. But of course, one should try to figure out the reason for the disease.
Thank you, Fabian. Over to you, Liman.
So I'll tell you what we did. So we replaced his immunoglobulin and did and put him on valacyclovir to treat this possible CMV infection. We also investigated further, did a colonoscopy. There was no CMV colitis at this point. Sorry, it was valganciclovir. And interestingly, the valganciclovir did suppress the viral load and the CD lymphocyte count became normal. So all of that concern with LGLL and it was actually a reactive change in the bone marrow as well. The other important thing to note is that the first bone marrow had ruled out a possibility of also a lymphoma, and his lymph nodes were most likely reacting to the possible infection he was having. So IVIG did not make a great deal of difference to the frequency of his chest infections. We started getting more frequent sputum testing. We identified Haemophilus, Candida pseudomonas in his sputum. And then he, out of the blue, developed this pain in his back, bony pain on the sacrum with sciatica type symptoms. And the CT scan showed lesions in the left sacrum bone and also in the right trochanter and a further lytic lesion in his first thoracic vertebra. He went to have a bone biopsy, and the histology puzzled quite a lot of histopathologists, but they could discern possibly granulomata which were poorly formed, fungal stains were negative. Was this a sarcoma? People were simply not very sure, but he started anti-TB treatment at this point, quadruple therapy with rifampicin, azonide, ethambutol, and pyrazinamide. He had a second bone marrow biopsy at this point. Again, we're searching for TB and no answer, no lymphoma and no clear TB. He had a further CT scan as a follow-up to see whether the anti-TB therapy had made a difference to the bony lesions. In fact, the bony lesions had progressed and his pneumonia was persisting, particularly on the right side, and his mediastinal lymph nodes were also remaining enlarged. Further follow-up, another CT scan, this was probably about 4 or 5 months later, we could actually now see multiple areas of calcification in his lung, liver and spleen, but particularly lung and spleen. And at this point, even though we hadn't suspected initially with the normal T cell number and the CD8 T cell number coming down, we did a T cell proliferation, and in fact, he had an absent T cell response to Candida and PPD antigens and a suboptimal response to the mitogens and the other antigens. So, question 2: where do we go from here? What would be the best test to do next? And I have A, lymph biopsy, B, repeat lymphocyte immunophenotyping, repeat sacral bone biopsy, or should we look for beta-D-glucan?
Gosh, it's more interesting now getting in. We'll give now another 5 seconds, and then we close the voting at 25 seconds. And maybe Sylvia, do you want to comment so far about the results we have and the treatment so far and investigation?
Okay, I see the results right now. This is a very challenging, I like very much this case. Thank you. I could go for repeat lymphocyte immunophenotyping. It's a combined immune deficiency. It looks very much like a common variable immune deficiency combined type. And I don't know, it looks to me like it could be NKT leukemia. Lung biopsy, of course. I'm doubting between both.
Thank you, Sylvia. It's all about expect the unexpected. Over to you, Liman.
Yeah. So this, I don't think we can take credit for this. It was one of the respiratory physicians, again, who did this. And so they were desperately looking for everything. I think he had glucomannan, and then he had blood beta-glucan blood levels, again, which would be positive in fungal infections, and also in what's happening here, which is, so his beta-glucan levels were very high. And then he had Pneumocystis jirovecii. When we started looking for it, we were finding it everywhere now. So he had it positive in the sputum, in the bronchoalveolar lavage. The bone biopsy that was previously taken, the histopathologist tested it again, and there it was. We were using the PCP terminology, which is why my slide has that, but obviously it's Pneumocystis jirovecii now. And we restained some of the histopathology, and there it was. We actually found the pneumocystis in the bone, and the granulometer were difficult to, there had been commented that it was a granulomatous process, but they were very poorly formed. There was amorphous material, which is probably what we're detecting on the CT scan as calcification. And he started treatment with high-dose cotrimoxazole, so 1,960 a day, and he actually started improving. His bone lesions started becoming smaller, inflammatory markers improved, he started eating better, he was feeling better. He comes for immunoglobulin replacement to our hospital, so we see him frequently every 3 weeks, and he was looking much, much better. He even thought about going back to work. But then he developed ascites, and this is probably the most challenging part still of what we're dealing with him. It was quite extensive. It required drainage. Acidic fluid was positive for PJP, and there was some issue with maybe cotrimoxazole doses being dropped down and him becoming unwell, but so we were insisting on those levels the treatment levels staying up. He then developed hemolytic anemia. I mean, how does somebody with no immunoglobulins develop hemolytic anemia? He has a little bit of IgM, so maybe that sort of is the answer there, but he had rituximab. His B cells went away, obviously. Then later on, he developed a lump on his neck and then found out this was a squamous cell carcinoma. He had that excised. Liver biopsy showed noduloregenerative hyperplasia, and he started also developing clinical signs of further T-cell dysfunction. These are obviously the E is a mild issue, but he's doing okay, but in some ways not so good either. So my next question.
We have got 3 minutes left, so we'll just go ahead.
I'm going to wrap
questions.
So next step in his management, again, this captures 2 questions in one: diagnosis and management. What would you do with this man now? So would you continue the high-dose cotrimoxazole? I should have said high dose. We know that if we drop the levels, he becomes more unwell. Would you continue that? Continue with his IVIG? And would you think of genetics, or do you think sort of this is maybe a combined bit of the CVID diagnosis umbrella, and bone marrow transplant would be too risky? He's not that well. So A, would you continue IVIG? You would think of maybe another anti-PJP antibiotic. You wouldn't really think of genetics just yet. Would you continue IVIG cotrimoxazole, but think of genetics and even think of maybe adult bone marrow transplantation? Or would you do D? You would think of maybe some immunosuppression for autoimmune complications.
Thank you, Lemon. So I've got a kind of a consensus here. So maybe Fabio, if you want to comment on the results so far.
Yes, so I agree with the respondents. Really, of course, this would be a difficult transplant, but this person was a marathon runner, you said. So this is somebody that certainly has expectancy of life higher than anybody else at this kind of a clinical situation. So I would not take the transplant off the table at all. And I would certainly pursue the genetic studies. And I think this is important. I don't know. I forget the family history and whether or not there are kids in his family that will obviously benefit from a genetic diagnosis. And anyway, that would give us some indication as to the outcome and the progression of disease, even the outcome of the transplant. So for me, C is the right answer.
Thank you. So, Limani, you've got only 1 minute left to wrap up.
And indeed, yes, that's what exactly. We are following that. Another antimicrobial is being considered, but essentially we've done his genetic study, and he's being currently being assessed for bone marrow transplantation with Emma Morris in London. Just to summarize quickly, he was a gentleman with A-gamma globulinemia. Just to mention the family history, sorry, I forgot to mention that. He's an only child, doesn't know very much about, his parents are non-consanguineous, he's not married and doesn't have any children. So he's kind of a one person. But at presentation, there was no T or B cell lymphopenia, but significant T cell dysfunction. Clinical course does have features of immune dysregulation. His gene test is, we did that. This is, I believe this was whole exome, NF-kappa B2 mutation of uncertain significance. So this is potentially a new NF-kappa B2 mutation. And remember his alopecia totalis story in his 20s. So that's potentially a significant finding. And my take-home message from this will be, think of not just fungus, but also the old PJP, PCP. That can cause this kind of picture. Granuloma are reported in the literature. This is not entirely.
Thank you very much, Liman. Thank you ever so much.
That's my case. Thank you very much.
Case. Thank you. In the interest of time, we'll go straight away to Boaz. So Boaz, you have got your case now to go ahead. You've got 14 minutes to do that with the discussion. So if you can enter your screen, Liman, and Boaz can get in. Thank you.
Okay, good morning. Thank you for inviting me. I'm a clinical immunologist from Florence. I'll jump right into the case. I have nothing to disclose. We were called to consult on a suspected dermatomyositis in a 41-year-old Caucasian male who was a construction worker who was under treatment with amphotericin B for laryngeal leishmaniasis and was actually hospitalized for worsening renal function and elevated CPK. The patient presented in good general conditions, and he had this very marked periorbital swelling and erythema. He is a son of non-consanguineous parents. His father died in his 60s for gastric adenocarcinoma, while his mother was healthy. He has 3 healthy sisters and 1 brother that died in his 20s for an unspecified lymphoproliferative disease. Past medical history was notable for visceral leishmaniasis as age 13 and frequent episodes of upper airway infections and 1 pneumonia in the childhood. He was in general healthy though. However, upon review of the medical history, it actually came up that he had several episodes of elevated CPK in the past, but they were also always attributed to his hard work and to the fact that he had a hobby of boxing. Moreover, the eyelid swelling actually dated back to 2013 when it was first misdiagnosed as Morbihan disease, which is a rare cutaneous condition. And only in 2019, after developing dysphonia, he underwent a laryngeal biopsy where he was shown to have mucocutaneous leishmaniasis, and by PCR, leishmania was also isolated from the old eyelid biopsies. At this point, the blood work showed elevated creatinine and CPK. The autoimmunity panel for myositis was actually negative. CBC was quite unremarkable. So this is my first question. Would you suspect an immunodeficiency at this point? Yes, no, or do you want to cheat and say yes just because this is an unexpected case?
I love that. Everybody going for C, I can see here. I think before we're going to discuss with the expert panel, I might just straight away go to you, go for the next section of the presentation, and then we go to the next question.
Okay, let's see the results. I guess everybody said C. Yeah. And indeed, so we said, well, I don't think this is dermatomyositis, but recurrent leishmaniasis sounds very interesting. So let's do some more testing. And we asked for more labs. He had very reduced IgGs, mildly reduced IgA, normal IgMs. Lymphocytes populations were mildly reduced with a reduced CD4-CD8 ratio. He had low B cells and low NK cells. B cell subpopulations showed a markedly reduction of memory B cells, in particular class switched. And T cell subsets were within reference ranges with the exception of T follicular helper cells, which were actually kind of low. Proliferation was normal, but production of interferon gamma and IL-17 after PHA stimulus was actually reduced. Okay, so now that you have a little more data, what would be your main suspicion? A common variable immunodeficiency, a form of combined immunodeficiency, a class switch recombination defect, an IL-12 interferon gamma axis defect, or you can take this and you just want to see the exam results.
Thank you very much, Boaz. I think we definitely need a comment from the expert panel here. It's getting more interesting now. So Fabian, do you want to comment on the results so far?
Yeah, I mean, I like answer E, but otherwise I would somehow consider imbalances in STAT signaling or hypomorphic variants in the cytokine receptors.
Thank you. So over to you, Boaz.
Should we go on? Okay, so here's the big reveal. We did exome sequencing and we actually found a variant in CD40 ligand. Yeah, so whole exome sequencing identified this missense variant in the CD40 ligand, which is absent in populations databases. It's in a highly conserved amino acid. It's predicted to be deleterious by multiple in silico scores. These variant substitutes a methionine with a lysine in amino acid 36, which is in the transmembrane domain. And this variant was actually reported in ClinVar, but without a phenotype. But another variant in the SAM residue was reported in an old CD40 ligand cohort. Interestingly, very few variants were actually reported in the transmembrane domain because most of the variants are usually nonsense or frame shift deletions and are found in the extracellular domain. So we went on and actually evaluated CD40 ligand expression on CD4 cells, and it was actually very reduced, but not completely absent. And this supports the notion that missense variants in the transmembrane domain probably reduce the expression of CD40 ligand, but without abolishing it, and therefore retaining some binding and signaling. And this could explain the very atypical, hypomorphic, and late onset phenotype. So to recap, at this point, we have our patient did not present basically any of the hallmarks of CD40 ligand of hyper-IgM X-linked. He had no neutropenia. He didn't have hepatic disease. His IgM were normal, which is actually been reported many times. And in hindsight, maybe one of the bigger clues was the fact that he had very reduced TFH cells. There was 3 other cases that we found in the literature of description of leishmaniasis as the actual onset manifestation for hyper-IgM syndrome. And the last one was published less than a month ago, actually. But what about the myopathy? Because in the meantime, the biopsy, the muscle biopsy came back and said that this is not an inflammatory disease and it's not toxic. It actually looks like a metabolic disease. So we went back to the whole exome data and we applied, we filtered with a gene panel from the panel app, which is a a website that gives you phenotype-driven app panels. And we found an heterozygous mutation in the carnitine palmitoyl transferase 2 gene, which has been actually associated, not this mutation, but other mutations were associated with stress-induced myopathy, which is triggered by infection, exercise, fasting, and cold. And upon review of medical history of the family, there is actually one of the sisters that is exercise intolerant and has chronic muscle pains. At the moment, we are still testing to segregate the mutation and to functionally validate it. And it's complicated because it's out of our expertise. So the final diagnosis was hypomorphic X-linked hyper-IgM syndrome and CPT2 deficiency stress-induced myopathy. The patient was started on EVIG. The mucocutaneous leishmaniasis actually got a little better, but in the meantime, the patient developed a hard palate lesion that on a biopsy was diagnosed as an extranodal NKT nasal type EBV-associated lymphoma. He underwent a first cycle of chemoradiotherapy and is currently in evaluation for a bone marrow transplant, which leads us to the last question, which is the usual, to BMT or to not BMT. This is the question. And would you do it only if you had a matching sibling? Would you do even a mismatch or unrelated transplant, or would you just wait and watch, considering the age?
Wow, this is so exciting. From the presentation to the treatment and diagnosis. So let's see what the vote, and I think, Sylvia, if you want to comment on the results so far from the voting and the diagnosis.
Exactly. I could go for even as the majority for even mismatched or unrelated BMT in this case.
Brilliant. Over to you, Boaz.
So we don't actually have an answer. I was curious to see what would you say, but I personally agree, and I think this patient eventually needs to be transplanted sooner than later. That is all. I just wanted to thank everybody for listening, ESID, and especially the Junior Working Party, and all my colleagues in the University of Florence and the KG Hospital. Thank you very much.
Thank you, Boaz. I'm just going to go to the expert panel. We have got a lot of questions. I'm going to try to summarize kind of the theme of the questions. We've got like 2 or 3 minutes left. So I'll start with you, Fabio. I've got a few questions about the SCID and the term of leaky SCID. Do we need to change that term for a different type of a late onset SCID or something? What do you say about this?
I completely agree. I think a leaky SCID is a delayed diagnosis SCID, rather, and especially for the case that Veneta presented. That presentation after a BCG vaccination is a typical SCID presentation. So it's very difficult, even the counts that the patient had during the history were typical SCID counts. Therefore, I would say that one is perhaps a SCID that presents a little later with some clinical findings that are in retrospective classical, but perhaps less overwhelming than the typical SCID. But leaky SCID, I never liked it because really it comes from the mouse models, and I think it's actually a little bit unrespectful or irrespectful of our patients. So I would say it could be a delayed presentation like it happens in ADA deficiency, or a late diagnosis with a milder phenotype, milder or atypical phenotype.
Thank you ever so much, Fabio. I think that's really a very kind of detailed comment. I'm going to ask just Fabian for a last comment before we close. We have got only 30 seconds left.
Comment on what? On the same issue, or?
on the SCID and the leaky SCID as well.
I mean, having had the phenotypic data from the cord blood already showing severe lymphopenia, I do agree with Fabio and probably all of you that this is SCID and that the patient should be transplanted. When it comes to the hypomorphic CD40 ligand thing, this is hypomorphic indeed, but in the case of the SCID patient, I think it is SCID. And additionally, maybe it has not. There has been somatic revertance as well in the IgM CD40 ligand patient, given the fact that the brother diseased early, because it's sometimes the phenotype can be planted by somatic reversions. So you could look for that as well, of course.
Thank you very much, Fabian. I'd like to thank everyone in the expert panel, all the presenters, and Hadil and Will for actually choosing these presentations and actually choosing the presenter, and all the organizers. Thank you very much for coming today, and I hope you've enjoyed and enjoy the rest of your presentation. Thank you very much. Enjoy ESID.
Thank you.
Great session. Thank you.
Thanks.
Bye.